I would like to invite Professor Arun Jain for his talk, which will be on the contact lenses, and which is the mainstay of visual rehabilitation and various designs for keratoconus. I think that's a
Okay.
mainstay of treatment that we have for
हो सकता है वो
these
बाहर नहीं
patients.
पहुंचे.
Sir, your talk, please.
Okay, can we have the slides? First of all, I'll thank Dr. Rajesh Sinha for inviting me to this instruction course, and I have been given this topic. Is contact lenses the mainstay of visual rehabilitation in keratoconus patients? As we all know, as the keratoconus advances a little bit, most of the patients come with the spectacle and they say they are not happy with the quality of the vision. So this study was done a long time back in 1998, which showed that whatever may be the stage of keratoconus, they need some type of optical corrections, and almost 80% patients of keratoconus need some type of contact lens, otherwise they don't get full potential of vision they have got. So whatever stage, whatever post-op stage, whether post CXL or post keratoplasty, you need some sort of optical rehabilitation, and I'm here to just share is contact lenses use is the mainstay of visual rehabilitation in these patients. So there are different types of contact lenses available to us in terms of soft and rigid and specialized lenses, more so the hybrid contact lenses. Indications of all are different for each patient depending upon the tolerability and size of the cone, the stage of keratoconus, and all those things. So we will come to these lenses one by one, and also it depends upon the grade of keratoconus. Like in mild cases where the K readings are lesser than 45, we can get away with these soft toric lenses or specialty soft lenses or a piggyback or a hybrid contact lenses, as well as rose K2 in early patient, because to improve the quality of vision, because rose K has aspheric design, it improves the quality of vision. In moderate cases, the mainstay of treatment is rose K2 lenses or hybrid, but in advanced cases where the K values are very high, we have to resort to large size rose K2 or scleral type of contact lenses. So depending upon the size and the location of the cone, also once we, yeah. So if the cone is small, paracentral, a contact lens fitting is quite easy. But if it is larger than around 5 to 6 millimeter, it becomes quite challenging, because the chair time required for fitting these cases is quite high. Maybe 2 to 3 times you have to change the lenses. That's why we have to have the help of specialized optometrists who are trained in fitting these lenses. And if it is almost covering whole of the cornea, you have to have a scleral type of contact lenses in these cases. Okay, thank you. So, right. So, coming to soft toric lenses, these are the type of toric lenses available in the market. These are only indicated in early keratoconus cases because they drape onto the surface of the cornea, so they correct only low cylindrical error. And the indication, as already told, early keratoconus, where RGPs are not tolerated, and spherical scleral contact lens has face to mask the corneal astigmatism. So rigid gas permeable contact lenses are the mainstay of visual rehabilitation in these cases, because the material is sort of high decay value and they are not very expensive. They correct the astigmatism to a large extent, and you get mostly 6 by 6 vision. But initial tolerability is low in these cases because there is a break-in period for about 3 4 weeks. After that, they are become more comfortable, and you can correct high cylinder and irregular cornea with these lenses. And based on the size of the contact lens, we can divide them into, so if they are covering the corneoscleral limbus, they are called corneoscleral lenses. Semiscleral are up to the 16 millimeter diameter. Once we go beyond that up to 18 millimeter, they are classified as miniscleral, and beyond that is full scleral lenses. And they rest on, depending on the diameter, either on the limbus or perilimbal or the peripheral sclera. So, fitting keratoconus has become quite easy as of now. It was way back 20 years ago when we were struggling with the fitting these patients. And today, this is the most common contact lens used for visual rehabilitation of keratoconus patients. The difference from the standard lens has a fixed optical zone and it doesn't correspond to the shape of the cone. And there is unwanted pooling around the cone. And these rose scale lenses have smaller optical zone diameter. They conforms to the cone, and so you don't have a pooling of tears around the cone. And fitting is very important in these cases. There should be light feather touch at the apex of the cone in these cases. This video is not working. So if it is too flat, it will lead to scarring at the apex as well as vascularization of the cornea. So it should have a feather touch in the center. And this is a represented case with the high K reading. And we did, you have to take all those specification required for contact lens fitting. We are not going into the details of that for the paucity of time. So this is how it should look like. There's a mild feather touch in the center, and there is no pulling of the dye around the cone. And this is another case where the high 6 diopter cylinder and visual acuity is quite low in the right eye. So these are the like a base curve of the lens. Then you have to decide the total diameter as well as the final power as well as the edge lift. Edge lift is also important because that is required for the exchange of tear behind the lens. And this is the pentagram of the case with very high K reading of 54 and 55. And this was fitted from outside and the fit was flat, so you can see there is scarring in the center because it is touching on the cornea. So that is not a good fit, and you can see so much of pooling in the eye. There is no feather touch, so it has led to a scarring. So we change the lens so that you have a feather touch in the center with minimal pooling. Otherwise, they will have a continuous progression of scarring in the center. This is a paper we wrote way back in 2006, and it is quoted widely. We described a new method of fitting contact lenses based on topography. Even Rose K, who invented these lenses, he written to me directly and he appreciated the paper. And now coming to the scleral lenses, as we have told, they rest on the sclera. And pros of these lenses are they have a good comfort, they are stable on the surface of the eye, they are highly customizable. They can be fitted almost in any case of advanced keratoconus or post-keratoplasty cases. And the handling is little difficult as well as they are very expensive. So that is the drawback of these lenses. And they are ideal for intolerant rigid lenses wearer regardless of the stage of the disease or main delay, and they can also avoid doing early surgery. So this is one type. So they have three zones: the central clear zone, a limbal independent transfer zone, and a scleral landing zone. So there should be a minimum of 150 to 200 micron clearance in the center, and mid zone is again should have a clearance of 50 to 100 microns. So I won't go into details of the fitting, and this should be the fitting. We should follow a 50-50 rule. There should not be too much impinging onto the scleral surface. it should not be like this. There's an edge lift. Edge lift will have, patient will be discomfortable, and this is too tight. It is digging into the sclera. So again, the exchange of tears, all those things doesn't happen. So this is an ideal fit in this case. And so this is a representative case with so much of refraction but highly irregular cornea, though the cone is central. And you can see there is a clearance of around 250 micron in the center, and patient gets a vision of 6/9 in this case. And this is the slit lamp picture of the same. You can see the accumulation of dye behind the lens, and you can if you don't have access to OCT, you can just compare this thickness with the corneal thickness. You can come to know how much is the approximate clearance. So this is the eye fitted with a scleral lens, and this is a post-keratoplasty eye. This is another post-keratoplasty eye. This can be easily fitted in patients of keratoconus who are fitted with these scleral lenses. So different stages of keratoconus, you have different options of treatment, either C3R or intracorneal ring segment or flick or PRK or phakic ICL or toric ICL, or a surgical treatment in the form of lamellar or penetrating keratoplasty. But whatever you do, patients still need some sort of optical rehabilitation in terms of spectacle. And if they have a irregular astigmatism, which is there in almost all cases, you need a spectacle or some specialized contact lens. So in the conclusion, I'll say for rehabilitation, optical rehabilitation of these keratoconus patients, you have to have knowledge of these different type of contact lenses. And if you are not doing yourself, you can refer to your optometrist or any colleague who is doing these lenses practice. And I acknowledge this optometrist who has done a lot of job in fitting these lenses. Thank you so much. If
Thank
have
you,
any
sir.
question? Yeah.
It was a wonderful presentation, and it's true that in cases of keratoconus, the mainstay of visual rehabilitation is contact lens, and even after DALC, nearly 70% of patients they do require contact lens. So that's very true, and with the advent of miniscleral contact lens, things have improved quite a lot, even in